Welcome to our newest episode of the Lebanese Physicians Podcast. And today our guest is Dr. Lama El Zein, and we will be discussing the financial sustainability in healthcare, especially with the rising costs in the United States healthcare system. And we will discuss it mostly in relation to palliative care and end-of-life care. Dr. El Zein actually did her medical school at the American University of Beirut, followed by a family medicine residency at Columbia University Medical Center. And then actually she was involved more and more in administration, and she became senior medical director for population health and clinician engagement at Emblem Health in New York City, where she was actually involved in population health management, crisis prevention, and financial sustainability of palliative care and home care programs. Following that, and probably just 4 weeks ago, actually, she started a big job, actually. She joined the Hackensack Meridian Healthcare System, which is the largest integrated health system in New Jersey, as Vice President of Quality and Implementation Science. She drives quality across the continuum of care beyond the hospitals, implementing high-quality, well-researched interventions into the daily, busy clinical life. Welcome, Lama, to the podcast.
Thank you, Khalil, for having me, and thank you for the introduction. And really, my dream and my personal why is really straightforward throughout this journey. I'm really on a continuous journey to make healthcare the safest and with the highest meaningful quality standard. The kind of healthcare I want to give to my family as a mom, as a daughter, and as a wife, and as an immigrant too. I want this high quality care to be accessible to all in the US and overseas in Lebanon and beyond. I want to reach this dream through small but incremental changes while continuously learning new fields, even if historically uncomfortable for physicians, such as the payer, as you mentioned. I believe this is how I'll be a conductor of change in this stiff, rigid, but high-risk healthcare system we live in. So I'm really excited about our discussion today.
Yeah, and that brings me, actually, that's a good segue to, so what made you choose this pathway? Because a lot of doctors finish medical school, you do your family medicine residency, and then for the most part, you're a clinician, you might be involved in some administrative endeavors, but what made you choose this pathway?
So I actually, I became a physician. That was always my dream. I did family medicine because I wanted to know a bit about everything and try to help across the continuum and many type of patients. And I did palliative care because that I felt that was needing in my training, that geriatrics and palliative care part was much needed. And I went into academia for first 4 years, teaching and doing quality improvement, teaching in residency medical school at Columbia University. And then I had another job after that due to a move in a physician group within an ACO. So we also doing clinical programs, building program totally new from scratch, but I was the clinician doing subacute rehab, home visits, and I had a home visit program that I built from scratch. I called it my baby for 2 years. Then for many reasons, including financial sustainability, we couldn't finish it. So I found that, at that point, that was a big reason why I needed to learn more and maybe do an executive MHA and learn as a physician how to sustain my program and, to reach more and more patients. So I did that, and this led me to go outside my comfort zone and understand the payer side, which was very important to be a physician leader and to do program on a bigger scale. I always knew that I would be on the delivery side. So the two sides that I want to learn were the payer side, which I did for the past 4 years. And then I came back now to Hackensack and hoping to kind of put all of this knowledge, theoretical and practical, together in a fully integrated health system. And maybe one day I'll work for government. I think that's an important part that many physicians feel sometimes uncomfortable, but not now.
Yeah, exactly. And I think you're right. I mean, a lot of the medical school education that we get is mostly like medicine and not the payer side of medicine, which is increasingly becoming a big part of the medical system, whether it's in the US, I think, or in other countries. That's a very important thing to understand. And physicians need to get into this system. So as we talk about the payer side, can we discuss the cost of healthcare in the U.S. and how much is it as a percentage of the U.S. Gross domestic product?
U.S. Healthcare spending actually is growing and grew 2.7% just in 2021, reaching $4.3 trillion, or about $12,900 per person. So as a share of the gross domestic product, the healthcare spending account in 2021 for about 18.3%. That's excluding research. And it's projected that in 2040, about $1 in every $3, which is about 33%, if we continue on this trend, will be spent on healthcare. And when I talk healthcare, I'm talking healthcare services. I'm not talking innovation and research, which a lot of the time we say we spend a lot of money on healthcare because we are innovative. We're talking just pure the services that we provide on every day. And if we look back to the probably in 1970s, between comparing US and with comparable average countries from the OECD, we were about 6.5%. The average other country, developed country, were about 4.5%. So we're pretty similar, a little bit higher, but pretty similar in the 1970s. And the curve kept growing and we went apart. And now in 2021, we were about 18.3%. And they increased to about, for average, about between 10 and 12%. So you can see the vast difference between the US and others, which is not sustainable in terms of cost, but also if we put on the x-axis the healthcare spending and the y-axis the quality or the performance, the US is on the lower right side, meaning very high cost and still lower performance, the lowest performance actually compared to the developed countries. So that's really not sustainable with the continuous growth in cost and the low quality we have. And what I mean by low quality in the performance system, it's we have the lowest life expectancy among developed country. We have the highest infant mortality and maternal mortality in this OECD country. We have the highest disease burden with 70% of the population above the age of 65 having 2 or plus chronic condition. We have the highest obesity rate. We're going to talk about palliative care. Actually, especially a metric from the OECD, we're not as bad in death in the hospital. We are, third best after Netherlands and Switzerland, with 35% of our death happening in the hospital versus like other countries such as Japan or Korea and Japan being in the 70%. So there's something wrong with that, with this kind of two side of the story that is not sustainable, and we need to do something about it.
Right. And I think, we're not going to get into the factors here, but I think there's multiple factors in the US healthcare system that lead to this, including maybe a lot of bureaucracy, a lot of middlemen, stuff like that. But I think for some reason, probably if I'm not mistaken, the cost of healthcare is like the highest towards the end of life, right? Is that true? And why is that?
So it's not necessarily the end of life. So let me explain that, and just a little bit of nuance here. I mean, in general, the healthcare spending happens about 30% in the hospital, other healthcare settings such as residential personal care, what you said about health insurance and administrative costs is about 25%, physician services about 20%, retail pharmacy, pharmaceutical about 10%, and have nursing care, dental, other services for the remaining about 10%. So still the hospital is among the highest, but that's in terms of setting. In terms of population, usually we don't have a normal distribution. So if you take the average or the mean of all of the population, usually the 90% of the population, the whole population in the US, spend 50% of the cost, and the top 5%, so 95%, spend the 50%, and the top 5 to 10% spend the rest of the 50%. So there's a small population that usually what we call population with high cost, high need, that is usually where a lot of the spend, and usually the lowest quality, because these end up they really definitely need a lot of care because they're sick, but usually they end up being in the hospital unnecessary, and there's a lot of preventable spend there. That being said, this population usually is characteristic, the top 5-10% or the top 1% of the population. Some of it is end of life. There was a study done in 2017, I think, in Mount Sinai, and they looked at the high cost population, this like top 5%, and they found 18.2 million are usually these high cost population. 2 million of them were in the end of life, like at the end, they died at the end of that year. So you have 16 million, they were not in the end of life. So definitely the 2 million is part of this to a big 18 million, but it's unfair to say that if we change the way we look only at end of life, and it's going to fix the US healthcare cost. It's part of it, especially that in that year, in that study, 2.5 million died that year. As we said, 2 million were in the high cost. So definitely there is a lot to do, because 2 of the 2.5 million were really dying in a high cost setting. But not necessarily the hospital, but in a setting like a lot of chemo maybe given to them, or a lot of medication towards the end of life. But it's not the only problem. The other 16 million, and usually their characteristics are people with frailty, disability, people of 3 more conditions who are not necessarily at the end of life, but they have chronic comorbidities that they live with them for years, that we need to think about them differently and put resources for them a little bit differently, in terms of not wait for them to come to our clinic, but outreach to them proactively, have a care management for them, have home visits for them, a specific program, EMT program that visits them at home, longitudinal care. So these are the type of care that we need to take care of these population, and definitely paying us bigger attention to this population at end of life.
Yeah, so basically what we're talking about is home health and maybe chronic disease management programs to prevent people from getting admitted to the hospital for one population of patients. And then maybe the other population, and I know you've had some training in palliative care, maybe palliative care services, or maybe more goals of care discussions with the family to decide on what's the best treatment options to keep their family members comfortable, and not maybe treat them unnecessarily in that case.
Exactly, and that's what palliative care is all about, to be trying to help that.
Because you've done, which I didn't mention at the beginning, you've done training in palliative care too.
Yeah.
That's correct. And so there's a lot of people who say, okay, palliative care, I'm going to get a palliative care consult, and that means the patient's end of life. And but I think there's a lot of misconceptions about it that are probably hopefully changing over time now. But what does palliative care specifically mean?
So palliative care, per the standard Center for Advanced Palliative Care definition, which one of the big think tank for palliative care in the US and globally, is a specialized medical care for people living with a serious illness. So we didn't say end of life, living with serious illness. This type of care is focused on providing relief from symptoms and stress of the illness. The goal is to really improve the quality of life of both the patient, but also their families. So the extended kind of caregiver model. It's usually provided by a specialty trained team of doctors, usually palliative care trained doctor, such as myself with fellowship, and also a team with nurses, social worker, chaplain, pharmacists, depending on the extension of the team. And they work together and with the patient's doctor, depending if it's an oncologist, cardiologist, depending on the disease, to provide really an extra layer of support. And it's really focused on the patient's need and the patient at that moment, not necessarily linked to a prognosis or tied to 6 months or 1 year, which is different than hospice. And that's very important to find that distinction, because hospice definitely provide palliative care, provide all of the service we talked about, but hospice is a Medicare benefit. It's really linked to an administrative benefit that's provided by Medicare, but also other than Medicare, because it's a good benefit that is linked to a certain disease, a certain characteristics that a patient should have, depending on the disease. So if they have like a cancer, should be end of life, end stage cancer with like no treatment for chemo, available for curative, or some symptom management. If it's CHF, they should have certain criteria. So there's characteristic for the disease with an association that could be a prognosis of 6 months or less per the doctor. So those are two different things. Hospice provides palliative care, but palliative care goes in hospice, but goes beyond hospice, really to earlier in the disease to make a big difference and make sure the patient's quality of life improve. And the communication, making sure where the patient is and starting the conversation about their disease, the burden of their disease, what do they want, what are their preferences early on.
Right, because that's part of the main thing also for complex patients is communication with the family members and different teams not communicating at the same time or miscommunication. And that can lead to like family members not, I guess, knowing exactly what their goals are or what their decisions will lead to, such as, I mean, I work in the ICU, you see a patient who's complex, they get sick, and you talk to family members, you're like, oh, let's proceed with a tracheostomy and PEG tube placement, and then send them to a long-term acute care hospital. And that's when the course starts going up and down, and it's probably not a good course. But had the family members known what's going to happen, they may have chosen a different route for their loved one, I guess.
Right, and it's all depending on the patient is, right? So, or the family, where they are in their understanding. And palliative care, with the communication skills that the team usually have, plays an important critical role in that term, because, they, if someone is so emotional, you cannot give them more like prognosis, and this is A equal B equal C, and this can happen in your disease progression or your treatment. They are in a totally different, they are in the emotion part, they are in the denial part. So that kind of, and this is why the team helped. It's not only the physician's understanding or responsibility to do all of this. And this is why the importance of a team, where sometimes maybe the social worker will visit them for 2-3 days, because that's what they need at this point, or later on the chaplain, etc., or the physician, depending on the need.
And how has palliative care evolved in the US over time? And is it outpatient or inpatient or both? Mm-hmm. And then I'm going to ask you another complex question: how is the payer mix for palliative care services? Are they well reimbursed? Do payers acknowledge these services?
Yeah. So in terms of the US, palliative care is to provide palliation, right? And this was always the foundation of medicine, to make sure to relieve the suffering. But the movement actually started with the hospice care movement, often delivered by caregiver through religious institutions. So it started in the 60s with Dame Cicely Saunders, a British physician, in Great Britain, and she founded the first formal hospice in 1948. And the movement started trickling across the world. In 1990, the World Health Organization actually recognized palliative care as a distinct specialty dedicated to the relief of suffering and improving quality of life. This kind of helped expanding more. In the US, it was expanding a little bit more. And really in the US, from the 2000 to 2011-12, it's expanded a lot. And for now, and mainly especially in the hospital in the beginning, and for now, as of like 2020 or 2021, the latest statistics is about 83% of hospital of 50 beds and above have certain presence of palliative care team. The American Board of Medical Specialty recognized hospice and palliative care as a specialty in 2006. So that's also had helped a lot, that growth. But really, what is it, outpatient or inpatient? So the growth in that period was inpatient. But I would say in the last, 5 to 10 years, it grew beyond. So it grew to outpatient, to clinic. In the beginning, it was embedded clinic, like you would find palliative care specialists in an oncology center or in a heart failure, like a big heart failure center, a heart failure clinic. And then it grows to standalone outpatient palliative care. Then it grew definitely to a big, and we'll talk about it from the payer perspective, a big population health approach for a lot of the payer, which is home palliative care. And then also you mentioned long-term care, LTAC, and then subacute rehab, where also it's a very growing field in that aspect, because as we know now in subacute rehab, the patient who live there are patients who are too sick to go home, but too good for the hospital. So usually they end up in that settings, and they go on forth few days in the home, they go back to the hospital, back to rehab, ED visit, back to home, etc., and the circle continues. So there's a huge need there, and there's a lot of services that are being done in that aspect. I mean, in terms of the payment, we can talk a little bit about the value of palliative care, because that will explain a little bit the payment. But just in general, the payment doesn't do it justice, because our payment is still very much based on fee for service. And as you said, with this extended team work, that most of these services on a fee for service base and a time perspective, because you want to do this communication and all of these discussion, is not payable, right? Is not reimbursed. Is our system reimbursed based on productivity and just more and more services, which is totally opposite than that. Right. So I mean, there is definitely newer value-based program and models that really support that. And the more people and physician and health system take risk, the more palliative care makes sense to introduce that there. One thing I want to mention, which is a very dear topic to my heart in terms of palliative care, is primary palliative care. There will be never enough teams to take care of all of our aging population and the population who's going to have more and more cancer and chronic disease as we grow older. So really, and nor should it be, the solution really would be to have more doctors and teams who are primary specialists, either primary care, family physician, pulmonary, cardiology, oncologists, who have what we call primary palliative care skills. Know how to do the discussions, know when to stop, give the patients their need at that point, do good, decent symptom management, and refer to those specialists when needed. So that's really a growing part that is really essential to make sure we have a sustainability for our aging population.
Right, and that would be an important thing, because you want to try to do these services before the patients end up in the intensive care unit or elsewhere. Because at the end of the day, I mean, the goal of healthcare is to keep people comfortable, and sometimes we do things that are not keeping people comfortable or just prolonging their life for no reason.
Mm-hmm. Yeah.
So basically, have there been studies on how palliative care affects the cost of healthcare?
Yeah, there's actually a lot of studies about that, and about the benefits of palliative care and how it affects quality and cost. So I want to go back to like the basic definition of value. So if we take value is equal quality over cost, right? So quality in the numerator, cost in the denominator. So anything that increase quality and decrease cost will increase your value. So that program, whatever that is, will have a big value. So palliative care is one of those, because in terms of the Q, the quality, the numerator, it's really, a lot of studies have shown that it causes less depression, less symptom burden, people feel more control, the benefit extend, as we said, to the family, to the caregiver around you, so better patient experience, greater satisfaction, it reduces readmission, it reduces time in the ICU, this reduces discharge to home, and improve patient satisfaction. All of these, you live in the hospital, and all of us live in healthcare, are quality metrics that we are responsible of in CMS, in US News, in NCQA, all of these measures that we are responsible of against all regulatory bodies, including payers, are these quality metrics. So improvement of these quality metrics definitely improve value. And in terms of lower cost, also due to the decreased readmission, avoiding unnecessary hospitalization, treating at home, having the conversation early on, these are also led to decreased utilization and overutilization, which is a big part of the driver, as we just discussed, of cost. So this is where you see the great value of palliative care. And there's a very important study, actually, that is a landmark of palliative care study, was done in 2011 by Dr. Timel from Harvard, and was published in New England Journal of Medicine. It was specific for palliative care provided for patients with non-small cell lung cancer. And it has shown that there's a benefit in mortality. The patient who receive palliative care actually live longer because of all of the above. They live on average about 2.7 months longer. So there's also some type of mortality benefit for certain subpopulation that could be probably another, but not much studies was done in that.
Right, and here's the importance of exactly palliative care services that are early on provided to complex patients. But my question for you is: you look at you've discussed several things to decrease the cost of healthcare, including palliative care, which is increasing in the U.S. over time. We're discussing chronic disease management and home healthcare and ACOs and stuff like that, which are also affecting or are also taking effect because of a lot of the healthcare laws that came out. But you look at all of this, and the cost of healthcare is still continuing to go up. So what's going wrong, and how can we reverse this trend?
It's not easy, but I think it's not impossible. Definitely, it's not easy. We have to understand the challenges and understand the population we're dealing with. So definitely moving away from fee-for-service and paying for real values. Okay, not like sometimes a sophisticated calculated value, really what matters for the patient or when change morbidity and mortality. So really trying to be away from gaming the system to gain quality metrics, but really measures what matters most for the patients and change the real quality of life. What is different now is we know in the last few years that the status quo cannot continue. We talked about the value. We have an aging population. The family unit is not family anymore. We don't have the caregiver. They're not the patients, as usually alone, and you are in the ICU, and their loneliness is a big issue. So we can depend on the caregiver, but also we cannot depend on the workforce. We have a severe work shortage in general in healthcare, and specifically in the home. After COVID, people are asking for more home type of services. The home reimbursement is not good. So my belief really is two things. One is really pay attention first on short-term goal to how to move that is the waste. It's addressing the waste. The waste in the US is probably around $190 billion. Okay, and then there are studies after studies that shows that there is really small things that you can do in quality improvement in the area of failure of care delivery, so to fix that, or failure of care coordination, those small things, or some pricing failure that you can start on smaller basis. You don't have to fix the whole. If you only do 10 to 15% of this big waste in healthcare, before going to like bigger changes, there is something that we can slow down the trend on a short-term basis. So I think that is really, really very important. So on a smaller scale, if you are wherever you are in the healthcare system, in a hospital, in a clinic, in an ACO, really try to pay attention to, or even in pharmaceutical or in payers, where in your system, in your processes, in your quality improvement, that where you can do project that addresses the waste while keeping the quality high, so that it start kind of flattening a little bit some of the cost. And from there, we can move further for our longer term, which needed, like the longer term solution needs really a policy change. And we know how, Washington and the politics and how healthcare is stuck in the politics. This is more a long-term, my personal belief is, having accessible, equitable care for all is the way to go. And then we can start by advocacy from our own group of what is right for our own group in our own specialty, and how to decrease the waste. But really, and more healthcare people should run for office. Not me, I don't want to do politics, but really more people should run with healthcare background, and to run for offices to change things on the long term. But on the short term, as I can, these small things, looking at your processes, where is the waste, and try to cut it is the way to go.
Right, exactly. Cut the waste, but also that's why people should run for offices, because there's also a lot of waste in terms of with the payers, with negotiating with insurance companies, medication denials, pharmaceutical companies, drug prices.
Yeah,
There's
PBM.
a lot of stuff that can be cut down very easily, but that also needs policy, and that needs lobbying and advocacy. And I think that's what physicians lack at this point.
Right, exactly. And this is why, remember, as I told you, like where healthcare is, like the different setting, the cost. So each of us play a role, whether in the hospital, whether in the pharmaceutical, whether in administrative cost, whether in labs and stuff. So if you start small and build on small wins, I'm very very big on like do small wins, not go and change the world suddenly, because it's not possible. I think we can reach a certain stabilization to hopefully these long-term strategy to start taking effect when we do more blunt changes over time.
Right, exactly. And at some point that will need to be done because the system cannot sustain the way.
Exactly.
So actually healthcare spending may foreshadow defense spending very soon. I don't know. Yeah. So what does the future look like, you think?
I think the future really is a move towards look what matters for the patient. Try to have the language. I think language matters. I know we need to do some checklist and some things that, sometimes we say, oh, it doesn't make sense. These checklists in the EMR doesn't make sense. And why are we doing this and what matters? But I challenge myself first and challenge others to kind of be more systematic and more visionary in how to address this. Because if we keep saying this doesn't work and without changing it, it's just nothing's going to change. It's not going to work and the system's going to continue. So if we really want to change it, we want to embrace some of it that we can do to make sure we keep the lights on wherever we are, if you are in a hospital or if you are in a clinic, just to keep things moving, and people needs to work and people needs to be seen and patient needs to be seen. Make sure you have what matters for you and for the patients as your North Star while doing the checklist and while fighting for how to change. So proving on a smaller scale what works, show, and this is where a little bit of that knowledge of having the business side comes into perspective, because you need to kind of ensure that, when you present a program, you present how it affects the patient, which is very important, always should be your North Star, but also how it affects the system, how it affects the bottom line, because at the end of the day, the hospital needs to pay money or the clinic needs to pay money to make sure it sustains itself as a business where people live on salary from it and on wages from it. So I think that's really what really needs to change, keeping always patient first, but in your mind, just make sure whatever you're doing as a program, how you make sure, how is it financially sustainable, who are your stakeholder, how you make sure it continues, how you make sure you pivot if it's not working, and not being just attached to something just for the sake of it. And then putting it in the big context of like making sure that, there is always some growth and some work, whether you do it on a personal level or you do it as a society, to change more the politics and the policy on the long term. So I think this balance is very hard, but if we start with ourselves and every person do a little bit, I think we can reach something very soon. And I'm an optimistic person by nature, so I really hope this will work. And then this is why I'm here, and I'm embarking on this new journey, and I'm really hoping to help the team make a change.
Yeah, you beat me to. I was going to ask you if you're optimistic or pessimistic, but you are optimistic about the future of healthcare, and hopefully you will start small steps at your new health system, and make some big changes over there that hopefully will reflect on other health systems in the future.
Yeah, and we have to all learn from each other. I think that's very, very essential. We should not work in silos at all. We should be open to working with other health systems, but other fields. Don't be scared of outreaching the payers. There's good and bad people in every sector, right. Government and stuff. Just try to get the good in everyone, and try to align incentive where people are in time, what's their culture, what they stand for, what you stand for, and try to align them. Try to see where's the incentive in the system to make sure there's a financial sustainability for whatever you're doing. That's what's gonna, I think, change the needle a little bit.
Right, I agree. I think just getting people together from the different sectors of healthcare, because there's always a tendency to blame others for what's happening. But once you talk to other people, you can fix it together in that case. So thank you, Lama, for being on the podcast, and thank you for all the work you do in improving the quality of healthcare, and also at the same time trying to cut healthcare costs that are not sustainable anymore.
Thank you for having me, and it's a great podcast. I always follow that, to see how people are doing. Our Lebanese physician here and back in Lebanon, and I hope all of this knowledge that we gain here, we try to work as much as possible with stakeholders in Lebanon and the area to have this expertise again beyond the US.
Yeah, I agree 100%. Thank you.
Thank you very much, Khalid. Thanks.